Chitra?
Yes, ma'am.
Okay.
Good evening, everyone. Welcome to the seventh day of Rapid Revision Series in Oral Medicine and Radiology for Part 1 students, organized by Assisia College of Dental Sciences in association with ASMIC. Today we have two sessions. With extreme privilege, I would like to introduce the speaker for the first session, and before that, welcoming each and everyone to the session, including the participants and all the faculties present here. We have Dr. Krishna S. Kumar as the speaker for the first session. She's currently working as a reader in the Department of Oral Medicine and Radiology at Amrita School of Dentistry at the Health Sciences Campus, Cochin. She completed her BDS from Amrita School of Dentistry and her MDS in Oral Medicine and Radiology from KVG Dental College, Sulia. With keen academic and clinical interest in oral cancer, oral potentially malignant disorders, dental management of medically compromised patients, and the application of advanced radiological techniques in diagnosing and managing head and neck pathologies, she brings both depth and expertise to her field. Dr. Krishna has authored numerous national and international publications in index journals and has been recognized with Best Paper and Promising Paper awards at several national and international conferences. Welcome, Krishna ma'am, for the session, and over to you, ma'am.
Thank you, Dr. Chitra, for that introduction. So can I share my screen?
Sure, ma'am. Yes, it's visible. You can start the slideshow.
Okay. Is it in the slideshow mode now?
Yes, fine, ma'am.
Okay. So can I start?
Yes, please.
Fine. Okay. So without any delay, I will progress to today's topic, that is about the X-ray films processing and faulty radiographs. So what to expect from this topic? This topic is a topic with significant clinical, as theoretical, as well as practical implication throughout your career. That is because you need to know about X-ray films, about the faulty radiographs, what are the optimal diagnostic radiographs, etc. throughout your career if you are moving out with MDS or with your clinical practice also. Hence, because of its importance, it's frequently asked for university examination. In the following sessions, that is the essay question, short note or brief notes, MCQs, as well as for Viva. So the commonly asked essay questions include
Sorry, ma'am, the sharing went off. Yeah, it's coming. And okay. Now it's coming. Yeah, it's coming. Okay. It has come.
Okay. So the commonly asked essay questions include: what is a latent image and discuss about its formation, the types of processing and the steps involved in manual processing. The other common question is composition of developer and fixing solution, composition of radiographic film, what is an ideal radiograph, and discuss in detail about the causes of faulty radiograph with the appearances. Short notes commonly asked are the automatic film processing, which has been asked 5 times, about X-ray films, composition of X-ray films, classify intraoral X-ray films, regarding the penny coin test, latent image formation, again composition and function of fixer as well as developer solution, X-ray film packet. Faulty radiographs have been asked for around 8 times, duplicating films and replenisher in radiology. So we will start with the first question, that is about the composition of X-ray films. So how should you approach the question? So this question has to be started with a brief introduction saying what an X-ray film is and what it does, what it carries, the contents of the film, the functions of each of these content, and you can illustrate this with diagrams. And it will be really beneficial. It will be really good if you can end it off with a reference. So what is an X-ray film? When the beam of X-rays passes through the dental arches, it is attenuated. That means its intensity is reduced either by absorption or by scattering. And the remnant beam which passes through the dental arches is recorded on an image receptor, which is the X-ray films. So X-ray films basically record the information about the object through which the X-rays pass through. So it consists of a base onto which the emulsion is coated either on one side or on both sides, and this emulsion is attached to the base with the help of an adhesive. And on top of that, you have a super coat which prevent any sort of damage to this base. So emulsion consists of the silver halide grains, mainly silver bromide or silver iodide, along with trace elements, sulfur and silver ions. So they are sensitive, these silver halide crystals, they are sensitive to both X-rays as well as visible light, and it records this radiographic image, or it records the information about the structure through which it passes. So here you can see multiple tabular crystals which represent the silver halide crystals. So the vehicle matrix is called gelatin. So this emulsion is present in this vehicle matrix, which keeps the silver halide crystals evenly dispersed, and it will help facilitate the chemical reaction between the emulsion as well as chemicals. Adhesive, as I told, it attaches the emulsion to the base. And what is the base? Base is made up of polyethylene tetraphthalate. It is transparent. It does not cast any shadow. It has a slightly bluish tint, which helps for better viewing, as well as it causes less strain to the eyes. It supports the emulsion, and it is non-inflammable, and it's flexible, and it is completely a safe material to use. And the super coat is a non-abrasive layer which protects this emulsion which is there on the base from any sort of injury, and it is made of gelatin. So that is about the composition of the X-ray film. It is usually asked for short notes also and asked for a viva. Next question, which will be a bigger discussion topic, is about latent image. What is a latent image? Describe how it is formed, what are the steps of processing, types of processing, and discuss in detail about the manual processing. So here also you can start with a brief introduction. You can explain how this latent image is formed, what are the types of processing available, and then you can write in detail about the manual processing. And make sure that you illustrate each of these steps like latent image formation with proper diagrams. And here, sometimes when you get questions like this, here there is mark division given. Certain questions carries 2 marks, certain sections carries 5 marks, etc. So that means the topic or the section which carries more marks, you are supposed to write in much more detail. And you can end with a reference, like from where you have taken the topic. So how does a latent image form? So when a beam of, so the X-rays, as I told, the emulsion, it is sensitive to both X-rays as well as visible light. So when this X-rays or visible light strike the film, there is alteration, chemical alteration of the crystals, which is sensitive to this X-rays or visible light, which result in chemically altered silver bromide crystals. And this is called latent image, and this is an invisible image. So this is a this is an emulsion. You can see this is a section of an emulsion which contains the silver halide crystals. So mainly the silver bromide crystals. There is free interstitial silver ions, and there are the trace elements which like sulfur, which forms the sensitivity site. So these trace elements, they store the energy and it reduces the patient exposure. So when X-ray photon strikes this crystal, what happens? It goes and strikes the silver bromide crystal. From that, an electron is being released. And this electron freely floats in this vehicle matrix. And because of its recoil energy, it moves towards the sensitivity site. And the sensitivity sites trap this electron, which will impart a negative charge to the sensitivity site. So as I told earlier, a silver ion is also present within the sensitivity site. So the silver ion will be attracted. The silver ion will be attracted to this negatively charged sensitivity site, and that will be also trapped, and it will become neutral silver atom. Now, this is the latent image site, and such several latent image sites will be formed over the entire film, which constitutes the latent image. So this is the same explanation. Here there are silver bromide crystals, the sensitivity spec, which contains the trace elements. Then there is the positive interstitial silver ions are present, which is freely floating. When the X-rays or light strike on it, it releases a negatively charged electron. Both the electron and the silver and the interstitial silver ions float freely in the emulsion. Electron moves towards the sensitivity side with its recoil energy, and the sensitivity side becomes negatively charged, which will attract the positive interstitial silver ion. And this forms the latent image, and after processing, it turns into the visible radiographic image. So before going into the manual processing, we will describe, as there was a question to enumerate the film processing techniques. The film processing technique include the manual processing technique, which includes the visual method, time temperature method, rapid processing method. Then there is the automatic film processing method, self-developing film, monobath method, daylight processor method, and digitized processing method. Among this, again, automatic film processing itself is a very important short note. So what are the steps which is involved in the manual processing? First step, we have to immerse the film in the developer. After that, you have to rinse the film in a water bath. Later, you have to immerse it in the fixer. Again, you have to wash it to remove the fixer. You can dry the film and mount for viewing. So what happens when you develop? So this is before immersion. There are many silver bromide crystals. After exposure, what happens? There is neutral silver atoms at the latent image site. This is the latent image. So multiple neutral silver atom or multiple latent image sites are present. When you develop, what happens? This exposed or these latent image sites are converted into solid grains of metallic silver. This solid grains, so this happens during the developing stage. When you fix it, the lighter shades of gray, that represents the unexposed or undeveloped silver bromide crystals. And these are the metallic silver, the developed ones. So when you fix it, what happens? All these unexposed silver halide crystals are removed. That is the fixing stage. So what does the developing solution consist of? It has a short note as well as part of the essay question. So it is DARP. Dark, developer, activator, preservative, and restrainer. The first one is developer. Developer is the electron donor. It consists of phenidone and hydroquinone. Phenidone donates the electron to the metallic silver ion to form the metallic silver. And when it donates the electron to this metallic silver, it becomes oxidized. So what happens? Hydroquinone is there. The hydroquinone provides an electron to the oxidized phenidone, which reduces it back to the original state of phenidone so that it can resume its action and convert all the silver ions into metallic silver. So developing solution is alkaline. Its alkaline pH is required for activation of this phenidone hydroquinone that consists of sodium hydroxide and potassium hydroxide. The gelatin matrix, and it also causes gelatin matrix to swell, which contains the emulsion, and that will facilitate the chemical reaction between the emulsion and the developing agent. Preservative is sodium sulfite. It extends or preserves the life of developing solution. It combines with the oxidized developer and it produces a compound. So if it's not washed properly after the developing stage, this oxidized compound, oxidized developer and preservative can produce brown stains. Now, the next DARP, the R is restrainer. Restrainer are the bromine-containing compounds. So if you keep on developing for a longer period of time, what happens is, other than developing the exposed silver halide crystals, the developing agent will start to develop the unexposed silver halide crystals, which has to be fixed and removed away. So if you develop the unexposed silver halide crystals, it will cause fogging of the film. So if you prevent the fog, that will increase the contrast. So after you develop in the manual processing, the film emulsion swells up by the alkaline activator and it becomes saturated with the developer. Later, the film is rinsed with water for 30 seconds with continuous gentle agitation. That will dilute the developer and slowly stop the developing process. And because your fixer contains an acidic agent, the removal of alkaline activator is very important. Otherwise, it causes neutralization of the acid fixer. So this rinsing step between developing and fixing is not there for automatic processing machines. So in your fixing solution, it is CARP, that is CARP, that is the clearing agent, acidifier, preservative, and hardener. So what does it do? As I told earlier, it removes the undeveloped silver halide crystals from the emulsion. Otherwise, it will result in dark and undiagnostic radiograph because this undeveloped silver halide crystals, if present for a longer period of time on exposure to light, it causes darkening of the film. And you know that after you're developing, your emulsion is full swollen up, which was there to facilitate the entry of the developer. So in fixing, it will harden the film and it will shrink the film to prevent further damage. So the fixing solution CARP, C is clearing agent, that is the ammonium thiosulfate. It dissolves the unexposed silver halide crystals, but if you fix it for a longer period of time, what happens is the grains of the metallic silver will be also lost in the fixing solution. There it was an alkaline agent, here it is an acidifier. Acidifier is acetic acid which maintains an acidic pH because that is essential for promoting the thiosulfate or the clearing agent into the emulsion, and it also makes sure that the combination of the unexposed silver halide crystals with this thiosulfate, that is silver thiosulfate complex, to move out of the emulsion. Preservative is ammonium sulfate. It prevents oxidation of ammonium thiosulfate as it is unstable in the acidic environment. Hardener, as I told, to prevent the damage of gelatin during the subsequent handling of the film, we have hardener, that is aluminum sulfate. So after fixing, definitely you have to wash the film, that is to remove all the thiosulfate ions and the combination of the thiosulfate with the unexposed silver halide crystal. And the water temperature should be maintained more than 60 degrees Fahrenheit. So if it's not properly washed away, this remaining silver compound or thiosulfate appear as stains on your radiograph. Now, what is replenishing? So every day you have to replenish your developing and fixing solution. Every day morning, you have to put 8 ounces of fresh solution per gallon of the developing solution, which is required for average development of 30 IUPAR or 5 panoramic radiographs. Now, so now coming to the other methods of processing, that is the visual method or sight processing. It's manual visual method. So it is done in a darkroom setting. The darkroom will have the darkroom should be properly light proof with a safe light of 15 volts or 7.5 volt. With 4 feet distance between the light and the surface where you are working on. And you have to use a GRX filter, that is you're filtering out the green and blue wavelength and allowing only the longer wavelength, that is the red light to pass through, because this red light has minimal effect on the X-ray film. So after making sure that the darkroom settings are proper, you open the film that is placed in the developer solution, and if the developer, the person who is developing, the person who is handling it, every time they have to see the film. They have to take the film and make sure that the degree it is properly developed. The radiopaque structures like enamel and all are properly seen. So it is basically dependent on the person who is handling it, and the film is viewed under safe light. So the operator stops the development based on the appearance of relatively radiopaque structures. So what are the advantages? Advantages is that we can adjust the developing time. That means if there is an overexposure, if the exposure parameters were quite high, if you develop it for a longer period of time, the film will turn very dark. So if you think that it was overdeveloped, then you can overexposed, you can reduce the developing time. What are the negative points? It is really time consuming. In a larger practice setup, it takes a lot of time for each film to be manually checked, and it relies on the operator judgment. The second type is the time temperature method, which has 9 steps. The first step is that we have to make sure all the solutions are completely replenished. That means the film should be completely dipped into the solution. Then before starting, the solutions should be agitated properly so that the chemicals are mixed, and you should use different mixing spatulas or paddles for developer and fixer to prevent cross contamination. Later, on a safe light illumination, as we discussed earlier, we can remove the packet, mount it on a hanger, using the holding the edges and not touching onto the base of the film, and label it. Then you can set the timer depending upon the temperature of the developer and the manufacturer instructions. Depending on, we can set the time. Then after setting the timer, you have to place the hanger with the film in the solution. Initially, for 5 to 10 seconds, you have to agitate to remove the air bubbles, then allow it to get developed. And that time, you avoid any sort of agitation. So set the time according to the manufacturer's instruction. So once the time is over, take the film from the developer, rinse in the water bath for 30 seconds by agitating it to remove the excess developer, so that the development process is slowed down, so that we can proceed to fixing. Then keep the hanger with the film in the fixer for 2 to 4 minutes and agitate for 5 every 30 seconds. That will eliminate the bubbles. And when you agitate it for agitate for 5 seconds in between an interval of 30 seconds, it allows the fresh fixer to contact the film. Later, you have to wash it for a running water in a time of 10 minutes to remove any sort of silver thiosulfate compounds and gently shake off the excess water. And then you can keep the film in a dryer in a circulating moderately warm air. And after drying, the film is ready to use. So next technique is rapid processing solutions. So in rapid processing solutions, it is done in a very shorter period of time. Developing takes only 15 seconds. Fixing takes only 15 seconds at a room temperature. So it contains more concentration of developer. So because of that, there is increased facilitation or increased entry of the chemicals into the emulsion. Then you can view it, then you can fix it for 4 minutes and wash for 10 minutes in running water to improve the contrast. So it's very useful in situations, in emergency situations or in endo purpose. But the disadvantage is that because of its rapid processing nature, its contrast is very poor. And if you don't wash it properly, discoloration or staining of the film will be seen. Now, coming to automatic film processing, it is a very time-saving method. That is, these whole steps, developing, fixing, washing, and drying, it is finished in a time of 4 to 5 minutes or 4 to 6 minutes. There are daylight loading machines also, which is very commonly used in private clinics, which avoids the darkroom setup. But we have to make sure the infection control is being maintained. So it's not operator dependent. So it helps to maintain a uniform density and contrast. But compared to the manual visual method, automatic film processing uses high temperature and there are rollers. So that can result in the production of artifacts or compromise the contrast. It is very expensive and it has to be cleaned frequently according to the manufacturer's instructions. And you know that the fixer contains the hardener. So hardener protects the gelatin from any sort of injury. So in automatic film processing, hardeners should be used additionally because it moves through a rigorous movement. We are not handling it with our hands, it goes through the rollers. So to protect it from those vigorous movements and improve the transport, the hardener used in the fixer should be more than the manual technique. So there is an inline arrangement. There is an inline arrangement with a transport mechanism which carries the film through the developing solution, fixing solution, water wash, then it gets dried and the film exits. So there are multiple rollers which are driven by a motor. So when this question is being asked, you can draw this diagram also. So what are the function of rollers? It helps in moving the film through the solutions, and the motion of the rollers keep the solution agitated so that there is uniformity of processing. The solution is uniform everywhere, and in the developer, fixer and water tank, this roller will press onto the emulsion. It forces the solution out of the emulsion and soon the emulsion comes in contact with the fresh solution also. So that movement is also maintained by the roller, and the roller prevents the leakage of developing solution into the fixer tank to prevent cross contamination. So how is it operated? It's a standardized procedure, but regular maintenance, the quality assurance and infection control is very important. Equipment should be clean to prevent contamination. We should use dry hands and dry film. Film should be handled at edges only. And the temperature, as I told, is high compared to the other one. It is around 82 degrees for the manual technique. It was much less. The rollers should be cleaned every week, and after cleaning of the rollers, you have to rinse and remove the chemicals which were used for cleaning, because otherwise this cleaning chemicals will interfere with the action of the developing or the fixing agent. Now, so after that, the next one is about self-developing film. Self-developing film are very simple to understand. It is very speedy also. Hence, mainly used for emergency and endodontics. So, this is how a self-limiting film will look like. So, after exposure of the film, there is a developer tab. You pull this developer tab, and the developing solution will reach the film. Then that film is pressed for around 15 seconds so that it is completely. It goes to all the places of the exposed film. After that, you pull the fixer tab. Then the fixer tab, then you again press it for some time so that it's completely fixed. For almost repeatedly, you have to press. And after 15 to 20 seconds, you can discard these chemicals and clear and wash the film in running water to clear these residues. So what are the advantages? As I told you, don't need a dark room and it's very time saving. But the disadvantage is that it is very expensive, and you can see these films are very flexible. So it's very difficult to place inside our oral cavity. And there is the image quality is very poor compared to the other techniques, and when it's kept for some time, the image quality again deteriorates. And there is no lead foil backing. There is only chemicals and the film. So the lead foil will prevent the scattered radiation from reaching the patient as well as the film. Hence, when there is no lead foil, there is increased radiation exposure to the patient. The next technique is monobath method. So in monobath method, there is developer and fixer in a single solution. So this solution is injected into the plastic wrapper, which consists of the exposed film, and you rub the film within the packet. So here, even though the fixer, in the conventional method, we told that the fixer cannot work in an alkaline environment. But here, in this monobath method, the fixer continues to work in an alkaline environment, which is present in the developer. Advantage is again very time consuming. Hence, it is useful for endo purposes. But the disadvantage is that poor image quality, shelf life is short, and it's very less effective for repeated use. The next technique is the daylight processor method. So daylight processor method, you will have a machine like this. The advantage is that you don't need a dark room, you have a safe light filter like this. Safe light red filter, so that there are two gloved compartments. In through one gloved compartment, the hands should be dry. The film should be held by its edges. You insert your hand with the film inside this compartment, and you unwrap the exposed film, and the processing steps are being carried out. But when you have to make sure that there is no light entry while removing or inserting your hands inside the daylight processing method. And again, the quality, the infection control has to be properly maintained. If the gloves are spoiled, it has to be replaced, and it has to be kept from bright light sources to prevent an accidental exposure to the films. The last processing method is digitized processing method, which includes computed radiography system and digital radiography system. So here there is a cassette. Instead of the conventional X-ray film cassette, you have an IP cassette. It is loaded into the reader after an exposure. After reading the image, the cassette is being cleared off, and the captured image is transferred into the workstation to your computers, where you can modify the image according to your requirements. It is stored either in computer or printed or CD, or it is transferred interdepartmental transfer or emailing of the images can be done. The second method is the digital radiography system. Here there is no cassette, there is a sensor, and the sensor is directly connected to the workstation via wireless networks or cables. And as soon as the it is exposed, you can view it in the image processor. After the adjustments, it can be sent across to the patient or to other departments, or you can store it in your system as per your requirement. So that was about the latent image formation, developing and fixing solution, and the types of processing, and in detail about all the different types of processing. So now we'll move on to a short question, that is classification of intraoral X-ray films. So you have to start with a brief introduction, as I have already told you about what are X-ray films and what it records. You can quote a standard classification, and you can quote from where did you take that classification, and then in detail about each subtypes. So the introduction, it is a X-ray films or image receptor system. What are it? Records the information about the structures through which the X-ray passes. So what are the classification? Classification, it's based on its use, based on emulsion coating, based on exposure, based on speed, based on sensitivity, based on packing, and based on film size. So most of my contents for this particular topic I have taken from the latest edition, White and Farrow, the third Southeast Asian edition to be precise, which was out in the year 2025. And this particular topic has some details which is also taken from the textbook of Oral Medicine and Radiology by Piyush Shivahari. So coming into details about each one based on its use, whether it's used inside the oral cavity, extraoral films, or duplicating films. Intraoral films are periapical films, which is used to image the periapical area of the tooth. Bite-wing films, which is mainly used to view the interdental area or to find out about incipient caries. Then you have the occlusal films, which gives a larger view of the lesions of the palate, maxillary sinus, etc. Extraoral films are lateral oblique, which is helpful for viewing the body and ramus, the oblique sections. The panoramic radiograph, which helps us to view maxilla and mandible in a single radiograph. Cephalometric, mainly for orthodontic evaluation, and the skull radiographs. So here you have the occlusal radiographs, the standard periapical or bite-wing radiograph, and the pediatric radiographs, which is used for the pediatric population. So this is a cephalometric radiograph, lateral oblique radiograph, and a panoramic radiograph. Based on the emulsion coating, it is single emulsion and double emulsion. Based on the speed, it is slow, fast, and hyperspeed. Slow films include A, B, and C. Fast films include D, E, and F. And there is a hyperspeed G. Based on the packing, there is single film packet and double film packet. That means single film in one packet and 2 films in one packet. Based on the sensitivity, it is screen films, which uses an intensifying screen, and the exposure is indirect exposure. That means the visible light exposes the film. Non-screen films are the one which we use in the intraoral region, that is the normal IUPAR. They work based on a direct exposure. That means directly the X-rays are exposing the film. So coming into detail about the use and size. Periapical films is an intraoral film and it has 0, 1, and 2 sizes. The smallest size is used for children. The second size, 24x40, is used on anterior teeth in adult. And this dimension, you should definitely remember that size 2 is the standard film which we use for the anterior and posterior teeth in adult. Similar for bite wing, 0, 1, then 2 is the standard film. The size, so there is 0, 1, 2, 3, and 4. The second one is the standard film, that is 31x41 mm size. Size 3 is a long film. It's an extra long film where you can view all the posterior teeth in one single arch. Then there is the occlusal film, that is size 4, 57x76 mm, which gives us a better view of impacted tooth, salivary stones. It was very, very used before the widespread use of CBCT. So this size you should also know, very commonly asked for Viva and MCQ, that is 57x76. Extraoral films are TMJ, lateral oblique, cephalometric, skull radiography, and panoramic. For the TMJ, the size TMJ and lateral oblique, it is 5x7 inches. For cephalometric, it is 8x10. Skull radiography, much bigger. 10x12, it is mainly useful for the evaluation of facial bones or skull or sinus. Panoramic radiograph is 6x12 inches, where you can see, as I already told, maxilla and mandible in one radiograph. So the occlusal film, 57x76, the standard periapical, 31x41 mm, and the pediatric film. This is the extra long film which is used for bite-wing radiograph or viewing the posterior teeth in one arch. Based on the emulsion coating, it is single coated and double coated. Single coated means you have emulsion only on one side. They are double coated means there is emulsion on both sides. That is, film the double-coated emulsion films have less patient exposure because you have emulsion on both sides. The energy is taken up by the emulsion on both sides. So the amount of X-ray required to expose a double-coated film is less compared to a single-coated film where you have only emulsion on one side. But because it is single-coated, it produces sharper and better image. That is because in double-coated images, the density which we see is the sum of the average density of the image of the emulsion on the both sides. So the single-coated emulsion are much more sharper than the double-coated emulsion, but patient exposure is less for double-coated. Hence, we use double-coated films very common. So this is a double-coated film. Onto the base, the adhesive attaches emulsion on both sides of the film, whereas in single-coated film, emulsion is attached only to one layer of the base. On the other side, you have an anti-halation layer, which prevents any light leak into the base. So based on exposure, you have direct exposure films. That is for the normal intraoral periapical radiograph where X-ray exposes the film. In indirect films or screen films, you have the presence of an intensifying screen. It is mainly used in extraoral radiography where large amount of X-rays is being used to view the structure. So to reduce the patient exposure, we use an intensifying screen which converts this X-ray to large amount of light photons and that exposes the films. So here there is direct and indirect as well as screen films and non-screen films. The screen films or the indirect films are used for extraoral radiography. based on speed. Speed is the amount of radiation to produce an image of standard density. The slow speed films contain smaller silver halide crystals, which requires large amount of X-rays to pass through, whereas the fast films, that is D, E, and F, contains larger silver halide crystals, which requires less X-rays to pass through. And the size which we commonly use is size E. If you see a film on one side, there will be an alphabetic marking of E. Based on packing, you have single film and double film. Double film contains 2 films in a single packet, and the second film will be used as a duplicate film for insurance purpose or for patient records. Now, next short question, very commonly asked and a very easy topic, is about X-ray film packet. You can tell about X-ray films, the contents of the packet, along with describing its function in detail. So it contains of an outer packet wrapper, which is making it moisture proof and light proof. Then there is a black film wrapper, which protects it from light and heat. Then there is lead foil sheet and an X-ray film. The outer packet makes it moisture and light proof. There are 2 sides. The tube side, which contains the embossed on and dot, and that should face the tube. And this is the label side where you have all the writings that should face the patient's arch. So this embossed dot is used for side identification and always should be kept towards the tube head. Then you have the lead foil sheet that is placed. Lead foil sheet is present behind the film. This is the film, this is the wrapper, black wrapper, then you have the lead foil. So lead foil protects the film and the patient from scattered radiographs. So radiograph, the X-rays doesn't travel in straight line, it scatters everywhere. The scattered radiographs comes back to the X-ray film and it can cause film fogging, making it not useful, and it will be absorbed by the patient, increasing the patient exposure. So this particular lead foil prevents the scattered radiation from reaching the patient as well as the film. So your film, this portion, this label side should not be placed in front of your tube, the X-ray tube. If it is placed like that, what happened? This lead foil will absorb the primary radiation. Before reaching the film itself, the primary radiation will be absorbed by this lead foil and very little amount of radiation will reach the film, which results in a light radiograph. The radiograph will be light and you will get this tire tract or herringbone pattern, which corresponds to the pattern which is seen in the lead foil. So that is about the contents of the X-ray film. So along with those contents, you have to also write about the X-ray film, which you have discussed earlier in the first slides. So next is about duplicating films. You can tell what are duplicating films, what are its use, how does it work, and how is it different from a conventional X-ray film. So here, the film which you intend to duplicate is placed on this glass-topped cassette, or this is the photographic printing frame. Please follow my pointer. This is the photographic printing frame. Then you place this film, the duplicating film, over to this the emulsion side. It's only single emulsion film. It doesn't have double coating. So the emulsion side has to face this the emulsion side of the film, which has to be duplicated, and light is being exposed by holding it together, and that film will absorb that film will get all the details from this film will be passed on to the duplicating film. It is processed through conventional imaging, and UV light is the best light source to produce best results or with good contrast for the duplicating film. So mainly this is used for patient records or keeping as teaching aids, etc. And the images are of less resolution and high contrast. So the safe light, everything is the same, around 4 feet from the film surface, and it has only a single emulsion, and the emulsion side should be kept facing the emulsion side of the film, which has to be duplicated. So its processing steps it's quite different. The mechanism which is quite different from the normal processing. So in normal processing, the exposed silver halide crystals are developed, the latent image site, and during fixing, all the unexposed silver halide crystals will be removed, but making it optimal for viewing. But in this type, it is a direct positive image where all the exposed silver halide crystals will be removed, and whatever remaining, the unexposed silver halide crystals will be available for viewing. So if you increase the radiation exposure, there will be more formation of the exposed silver halide crystals, and that will be removed. Hence, so the mechanism of action during the processing steps is opposite to that of the conventional film. Another short note, and the one which is very, very commonly asked for Viva as well as MCQ, is about the penny coin test. Penny coin test is used to check for improper safe lighting or any damage to the safe light. So, in a dark room, after making sure it's completely light proof, you have to open the exposed film or an unexposed film in a safe light area. Then you have to place a coin over that film, and it has to be kept there, exposing it under 5 minutes. Expose it for 5 minutes under safe light, and then you have to process it. So if the coin image appears on the if the coin image appears on the exposed film or an unexposed film, that means that the safe light or the room is not light safe and the film is formed. So not only IOPAR, you have to check each type of film to check for safe lighting. So moving on to the next section of our topic. So we studied about X-ray films, we studied about processing, developing solution, fixing solution, the contents of the X-ray film packet, types of films, composition of film, etc. Next is about faulty radiographs. So faulty radiograph can be asked as such, or small topics from faulty radiographs may be included, or it may be asked as an essay question to define an ideal radiograph and also discuss in detail regarding the faulty radiographs with its appearance. So you should start with definition. The definition should be always a standard definition, and you can quote or cite from where you took that definition. Then with the brief introduction, you can highlight the classification along with its subtypes. Then you have to describe each of these subtypes with its cause and what image or what appearance does it produce, and end with the reference. So what is an ideal radiograph? The H.M. Wirth, the great radiologist, he defined ideal radiograph as the one which has desired density and overall blackness, which shows that part completely without any distortion, giving maximum details and right amount of contrast to make the details fully apparent. So this definition I have taken from the textbook of radiology by Dr. Freni R. Karjotkar. So what is a faulty radiograph? Faulty radiograph is diagnostically suboptimal. It results in the loss of a professional's time as well as patient's time. So this main classification I have taken from the recent edition of White and Farrow, where it has been divided into exposure and processing errors, projection and film placement errors, film storage and film handling errors. Coming to each of them in detail. So all these comes under exposure and processing errors, starting with the light radiograph. Light radiographs occurs when there is reduced exposure parameters. So when there is less KVP, there is decreased penetration of the X-ray photons into the X-rays. So naturally, it will be underexposed. When the milliamperage is also less, that also causes decreased amount of X-ray photon production. And exposure time. The exposure time is very short. The X-ray photons will not reach the X-ray film. And if you increase the source to film distance, also there is decreased penetration of the X-ray film. And if the placement of the film packet is reversed, if the lead foil comes in contact with the primary radiation before reaching the film will be appearing light. And when you do the processing, when the temperature is very low, when the time is very short, all these things will not allow proper chemical reaction between the chemicals and the film. Inaccurate thermometer, when the temperature readings are not correct or depleted or diluted developing solution, will not have insufficient chemicals to develop the film or contaminated developer with a fixer. That will also result in a light radiograph. And excessive fixing. If you fix the film for like half an hour or so, it will start removing the exposed silver halide grains also. Dark radiograph is again opposite. If you increase the exposure parameters, more amount of X-ray photons will reach the film. If the source to the film, when the X-ray film and the X-ray source is very close, that will also cause increased penetration of the X-ray photons. If you develop for a longer period of time, it will start developing the unexposed silver halide crystals. Also, same thing applies for high temperature or concentrated solution. And if you don't fix it, the silver thiosulfate compound will remain in the film, or the unexposed silver halide crystals will not be completely removed, which will result in dark radiograph. Other reasons are improper safe light and accidental exposure to light. So contrast. Contrast is the difference in densities between the adjacent areas. So we need, for optimal viewing, we need contrast between a mid-range, between high contrast and a low contrast. So in high contrast, there is shades of the grayscale is very short, whereas in low contrast you have a wide grayscale. So for high contrast, if the film is very dark, then it will be high contrast. If the film is very less exposure or less development, it will be of low contrast. And excessive KVP. Excessive KVP, what is the reason? When the KVP is very more, large number of X-ray photons will penetrate the structures. So instead of photoelectric absorption, there is Compton scattering. The differential absorption between the tissues, the soft tissues and the hard tissues, will not happen in such a case. There is increased penetration of the X-ray photons, and that will also result in low contrast. So, and the other reason is film fog. I'm sorry, that is film fog. That is because of that will also cause low contrast. So film fog is mainly due to improper safe lighting, which is improper wattage. So it is 15 watt or 7.5 watt. The distance of 4 feet is not being maintained between the safe light and work surface, and prolonged exposure to safe light. If the safe light is cracked or there is light leaks, that can also result in film fog. The reticulation or orange peel appearance, if there is sudden change of the temperature during processing. The blisters can occur if there is air bubbles trapped during the film or when there is extreme temperature changes. White spot occur if the film, before developing, it comes into contact with fixing or comes in contact with any other tank or during development. And dark spot occurs if before developing, it comes in contact with the developing solution or the wrapping paper adjacent to the film. Excessive bending of the film to fit the arch or roller pressure and dirt in rollers in case of automatic processing. Yellow or brown stains if you don't rinse the film after developing and fixing, and if it is contaminated. So clear film occurs if the film is not exposed at all. It will result in a clear film. Or before developing it, you fix it, then that becomes a clear film. Dichroic fog is seen as pink color in transmitted light and green color in reflected light. That also occurs after fixing. If it is not properly rinsed, the silver thiosulfate compound, it causes this fog. Black film occurs when the film got accidentally exposed to light. Partial image or cone cut when the film is not completely immersed into the developing solution. And brittle film occurs when in the automatic processing, when the film has been dried for a longer period of time, the film becomes brittle. The projection and placement errors include foreshortening when there is increased vertical angulation. Elongation occurs when there is decreased vertical angulation, and overlapping when there is improper horizontal angulation. So when the angle between the X-ray beam, the blue is the X-ray beam, and the bisecting line is more than 90 degrees, when the vertical angulation that will result in elongation. When the angulation between the when the angulation between the X-ray beam and the bisector. When it is greater than 90 degree, it becomes foreshortening. When it's short, it will become elongated. And the edge of the cone should be parallel to the buccal surface of the teeth. Then only the central ray will go through the interproximal areas of the teeth. Otherwise, there will be overlapping. Double image occurs when the film is exposed twice. Black line occurs when it is bended. Blurred image occurs when the patient cone or there is film movement. Herringbone pattern I have already discussed. Magnification occurs when the film to the object distance is very high, it will become magnified. When the film and the object distance is it has to be maintained in a less pattern to prevent magnification. Distorted image occurs due to movement of the film. Cone cut, other than improper development, it may be also due to the incorrect placement of the film or the film indication, position indicating device. Crown of the teeth becomes cut off when there is elongation or improper film placement. 2 mm of occlusal clearance should be there. Occlusal plane becomes tilted when the edge of the film is not parallel to the occlusal surface. Phalangioma occurs. Here you can see the surface bony project bone of the patient's finger. Incorrect placement of the patient fingers result in phalangioma. Black dot, the embossed dot should come on the incisal surface. When it is placed in the other way, black dot is seen in the apical area. Apical end becomes cut off when there is elongation and the film is placed in a manner where the occlusal clearance is more than 2 mm. You will not get a 4 mm apical clearance. Artifacts on radiographs can be due to jewelry, dental artifacts, or writing lines with a ball pen or a lead pen. The film storage and handling errors. First one is film foam. When the film is a deteriorated film, high humidity and used beyond expiry date. Emulsion peel occurs when you scratch off the emulsion with a sharp surface. Static electricity is seen like that as a lightening marks or branching lines, which occurs due to forceful opening of the film in an area where there is low humidity. The static electricity passes through and produce these lightening streaks. Fingernail marks are seen as scrims or crescent-shaped marks due to improper handling of the film on its base. So along with these errors, there are errors which is exclusively seen on the automatic processing machines. That is the pressure marks from the rollers, cloudy appearance of the film, or the white cloudy appearance, chalky, dirty films. It's all because of the dirt or the depleted developer or fixing solution, drying pattern due to excessive drying temperature, shiny films, or jam or failure of the films to transport when the roller is jammed and it is very soft. The films fail to move through the rollers. So I will be ending my session with the commonly asked MCQs. We have discussed all these things in our previous slides. I'm not going into detail about all these answers because of short of time. I've taken 10 minutes extra. Penny coin test, you already know, for checking the improper safe lighting function of lead foil to prevent the scattered radiation. Fastest dental film available is Hartner, is hyperspeed film G. Base of the X-ray film is composed of polyester tetraphthalate. Foreshortening occurs due to increased vertical angulation, elongation, the other way around. Overlapping occurs due to improper horizontal angulation. And initiating and developing solution is phenidone and hydroquinone. So any questions you can ask me or put in your chat box. Thank you.
Yeah, that was a very extensive session, ma'am, because the topic is little vast.
Yes.
Yeah, because it includes multiple parts and you have
Yes.
discussed like almost all the important questions and in detail actually. So
Thank
any
you.
doubts, participants? I've not seen any doubts in the chat box. It was very clear, I guess.
Thank you.
Yeah, the session was very good, ma'am, and very happy to say our gratitude, express our gratitude from ASMIC as well as from ASISIA, the organizing committee. I would like to share the certificate. Can you just stop the screen sharing, ma'am?
Sure. At the end, I would like to thank ASISIA Dental College and ASMIC, our parent institution, and Dr. Deepa ma'am and Raj sir for giving me another opportunity. This is the second time I'm coming as a speaker for the rapid review. And thank you, Dr. Chitra, for being the moderator of my session. Thank you.
Thank you. Thank you, ma'am. Very happy to share the certificate. Thank you, ma'am.
Thank you. Thank you so much.
So now we will move on to the next session. And I'm very happy to introduce my own colleague for the next session, Dr. Shehna. She is working as assistant professor in Department of Oral Medicine and Radiology in Malabar Dental College and Research Center. She has completed her BDS from Royal Dental College, Chalisheri, and MDS from Yenapoya Dental College, Mangalore. She have attended and presented papers in various national conferences, and she has numerous publications in index journals to her credit. She has been resource person for various CDE programs in several institutions, and we are very privileged to have Shehna as our speaker for today, and her topic for discussion today is normal radiographic anatomy. Welcome, Shehna. Over to you.
Thank you, ma'am, for the introduction.
You can start sharing the screen.
Okay, ma'am.
That's visible.
Yeah,
Start.
the screen, I have started sharing the screen.
Yeah, it's visible. You can start the slideshow.
Okay, first of all, good evening, all. So we'll directly go on to the topic. The normal anatomical landmarks seen in maxilla, in mandible, in intraoral radiographs. So now this is a topic which you have been familiar from your early classes in oral medicine and radiology because it is the very basics of interpreting a radiograph. So now why do you need to know the anatomical landmarks, normal anatomical landmarks? This is mainly because it is you should be able to identify the normal anatomical landmarks apart from the pathology. Otherwise, there are chances that you can mistake it a pathology for a normal anatomical landmark, or you can mistake a normal anatomical landmark as a pathology. Also, it is very important that you should be able to know the wide range of variations that can happen within these anatomical landmarks. For example, the position of a Mendel foramen is found to span a distance between a first premolar and the first molar. So you should be able to correlate it with the clinical pathology and identify if it is a normal anatomical landmark or if it is any pathology. So if you are very much familiar with the gross anatomy of a skull, it will be very easy to study these anatomical landmarks. The anatomy of skull is being studied from the first year itself. So when you look into the skull, you can see that the maxillary anterior teeth, above the maxillary anterior teeth, we are having the nasal cavity and the associated structures. Above the maxillary molar teeth, we are having the maxillary sinus. Below the mandibular premolar teeth, we are having the Mendel foramen, and below the mandibular molar we are having the external oblique ridge. So if you are well versed with the anatomy of the skull, it is very easy to study the normal anatomical landmarks which you can see in an intraoral radiograph. Now, before going into the anatomical landmarks, first of all, you should know what is radiolucent, what is radioopaque. So the term radiolucent means it appears black color in a radiograph. So now what are the structures that appear black color? Any structure that allow the X-ray to easily pass through it and hit the film will appear radiolucent. So what will be it? It can be remembered by using the short form S, F and C. So under S we have the sutures, sinus, soft tissue. Under F we have the foramens and fossa. Under C we have the canal and the cavity. So here you can see that all these structures contain either soft tissue or a air cavity or a fluid filled cavity. So all these structures will allow the X-ray to easily pass through that, so it will appear more black on a radiograph. Now those structures that appear radio opaque are found to block the X-ray to certain extent. That is why minimal amount of X-ray will reach the film and it will appear more white. So here you can by heart the short form by using S, B, R, C and P. Under S we have septum and spine, B for bone and border, R for ridge, C for concave and P for process. So now we'll go into the anatomical landmarks. So this is the list of anatomical landmarks that appear radio opaque in maxilla. So the structure which is common in maxilla and mandible will be tooth. So in tooth we have enamel, dentin, cementum, lamina dura and alveolar crust and the cancellous bone which appears radio opaque. And the other structures will be septum, nasal septum, anterior nasal spine, the floor of the nasal cavity and the maxillary sinus, inferior nasal concave, nasal labial fold, septa in maxillary sinus, inverted Y-line of NS, zygoma and zygomatic process of maxilla, the pterygoid plates, Hamler process, maxillary tuberosity, the shadow of nose and the coronate process of mandible. So now here you will be thinking why the coronate process of mandible is coming under the maxilla, that I'll be discussing in the further slides. So these are the radiopaque landmarks which you see in the mandible. So apart from the tooth structure, we have the genial tubercle, ridges and the inferior border of mandible. These are the radiolucent anatomical landmarks which you see in maxilla and mandible. So now coming to each anatomical landmark in detail. So first of all, we'll go with the tooth. So tooth, you know, we have a crown and a root. So crown is the outermost portion which we see in the oral cavity. It is having a outer covering of enamel, below which we have the dentin and the pulp cavity. So now enamel is the most dense mineralized structure in our body. So of course it will provide much hindrance to the X-ray. So that is why it appears more whiter in the radiograph. Just below that we have the dentin. Dentin is having a less denser than enamel, so it appears less whiter than enamel, and it is seen just below the enamel. Pulp cavity, it is seen enclosed beneath the dentin and it is found to appear as black. This is mainly because it contains pulp tissue. Now the pulp cavity extends as root canal space and into the entire length of root up to the apex. So it also contains soft tissue and it appears as a radiolucent line. Now the root structure, you know, it has a dentin layer and which is having an outer cemental layer. But here you are not able to appreciate the cementum from the dentin. It's mainly because cementum and dentin is almost similar in density. So you won't be able to appreciate the cementum and dentin separately as in case of a crown. Now coming to the supporting structures. Supporting structure, we have the lamina dura. So lamina dura is the layer of bone which lines the alveolar socket. So it is the layer of bone which is lining the alveolar socket into which the tooth is attached by the periodontal ligament fibers. It appears as a thin radio-opaque line of dense bone surrounding the tooth socket. So here you can appreciate a white line which is surrounding the root from the mesial aspect across the furcation area and into the distal aspect. So the radiolucent line, it is and also it is continuous with the cortical bone at the alveolar crest. So now this is a very important question which is mostly asked in the KUHAS examination. I'll be discussing the questions in the last. So many times the diagnostic importance of lamina dura have been asked. So you have to draw a knee diagram of lamina dura. Apart from that, the tooth and the lamina dura. Apart from that, you have to write about the radiographic appearance and also the variations in the radiographic appearance. So here it is thicker than the surrounding trabeculae of cancellous bone. So it appears more whiter with respect to the surrounding cancellous bone. And here, if you are not able to appreciate a lamina dura as a thick white line, you should not think it is a sure shot anomaly, because it is seen as radiopaque and well defined only when the X-ray beam is directed through the long spans of the structure. If the X-ray beam is directed more obliquely, then these lamina dura will appear more diffuse and not discernible. So you have to correlate it with the anomaly of the tooth. If there is any carious structure, then you have to identify if it is a periapical pathology. And the thickness and the density of the lamina dura is also found to vary with the occlusal stress happening on the tooth. So the tooth which is under heavy occlusion will have thicker and denser lamina dura, and those tooth which is not having any occlusion, if there is no opposing teeth, or if in case of any submerged tooth, the lamina dura will be less thick and less denser. There are some cases where you can appreciate double lamina dura. This is mainly because there are two surface elevations in the root surface. So it will create a double lamina dura appearance in a radiograph. Now, if there is any pathology happening, you can appreciate a breach in the continuity of the lamina dura. So the local pathologies include periodontal disease, trauma from occlusion, and periapical abscess. These are some of the local pathology that can cause a breach in the continuity of lamina dura. But if you see there is generalized loss of lamina dura through the entire radiograph, if you take for any panoramic radiograph, then you can suspect any systemic diseases such as hyperparathyroidism or osteoporosis. Now coming to the next supporting structure, we have the alveolar crest. So alveolar crest is the most coronal portion of the alveolar bone between the teeth. So it is the crest of the interdental bone. It appears to be sharp and pointed in anterior teeth, and it is flat in and with sharp angles in case of posterior teeth. Now the level of the alveolar crest will be either at the level of CEG or slightly below the CEG in case of posterior teeth. So up to 1.5 mm. Up to 1.5 mm below the CEG, you can consider it as normal. But if it goes below 1.5 mm, then that means there is some pathology happening there. And also if there is the sharp angles get round off, then you can suspect the periodontitis might be happening there. The other structure, supporting structure, is the periodontal ligament space. Periodontal ligament space will be, of course, as the name implicates, we have the periodontal ligament fibers. And these are the fibers which attaches the cementum onto the alveolar socket. So the tooth root surface which have the cementum is where the periodontal ligament fibers get attached, and the other side is the lamina dura, that is the tooth socket. So because it contains mostly connective tissue fibers, it appears more radiolucent. Now, according to theory, the periodontal ligament space appears more thinner at the middle of the root and more wider towards the crest and the apex. This is mainly because the middle of the root is thought to be the fulcrum of the tooth movement. And similar to lamina dura, it is more thicker and wider in case of tooth having more occlusion, and it is more thinner and less wider in case of tooth with no occlusion or any submerged teeth. And also double pedial space can be appreciated if the tooth root have two convexities. Now the last supporting structure will be cancellous bone. So you know cancellous bone is that part of the bone which is enclosed within the cortical plate. So the outer cortical plate will be very thick and dense, but the inside cancellous bone is very thin with large marrow spaces. So here you can appreciate the honeycomb pattern of the cancellous bone. So it is a soft spongy bone located between the cortical plane, and it is appearing more radiopaque with a crisscross pattern. And you can also appreciate there is a variation in the appearance of this cancellous bone in maxilla and mandible. In maxilla, it will be more porous than the mandible. And in anterior maxilla, it is more, we have smaller marrow spaces, and in posterior maxilla, we will be having larger marrow spaces. And in mandible, the cancellous bone is more denser in the anterior region. When we move towards the posterior side, there will be more larger marrow spaces. And when we take for mandibular molar radiograph, especially in the furcation area, you can appreciate that the cancellous bone, the bone septae is arranged in a ladder-like pattern. So you can appreciate a step ladder pattern in such areas. Now coming to the in detail with the anatomical landmarks in maxilla. So you know that maxilla is the upper dental arch and it contains the maxillary alveolar process, the maxillary teeth and the maxillary sinus, and it is situated on either side of the nasal cavity below the orbit. So there are certain landmarks which is specific for the anterior region of maxilla and the posterior region of maxilla. So now coming to the anterior region of maxilla. The first landmarks we should be aware is the incisive foramen. So you know incisive foramen is the opening of the nasopalatine canal. So as the name implies, nasopalatine canal is a canal which connects between the nasal cavity and the palate. So the inferior opening of the nasopalatine canal is incisive foramen. So it is also known as nasopalatine foramen or anterior palatine foramen, and it is opening just behind the maxillary central incisor on the palate. So when you take a radiograph of the maxillary central incisor, you can appreciate a round oval radiolucency between the root of central incisor, which is the incisive foramen. Now we have talked about the inferior opening of the nasopalatine canal. Similarly, we have a superior opening of the nasopalatine canal. So this nasopalatine canal, when it moves upwards, it bifurcates into two canals and have opening into the floor, either floor of the nasal cavity as two foramina. This is known as the superior foramina of the incisive canal. So when you take a maxillary anterior radiograph with steep angulation, you might be able to appreciate round radiolucency within the nasal fossa on either side of the nasal septum. So here you should be able to say that it is the superior foramina of the incisive canal. Now the next landmarks is the median palatine suture. So you know that the maxilla develops in two halves and it grows medially to fuse together at the mid-palatine suture. So it is the median palatine suture, also known as the intermaxillary suture, which appear as a thin radiolucent line between the root of maxillary central incisor on a radiograph. And you can see that this radiolucent line is having radio-opaque line on either side. With age, it is found to appear less. Now coming to the next one is the nasal fossa. So you know nasal cavity. Nasal fossa is the other name for nasal cavity. This is seen as large radiolucent area above the maxillary incisor. So the large radiolucent area above the root of the maxillary incisor is the nasal fossa. Now this nasal fossa is divided into right and left cavity by a thick radio-opaque band which is known as the nasal septum. Now the nasal septum ends in a sharp pointed projection which is known as the anterior nasal spine. So anterior nasal spine is appreciated as a V-shaped projection beneath the root of maxillary central incisors. Now the anterior nasal spine on either side, it extends into the floor of the nasal cavity. So the floor of the nasal cavity is having denser bone, so it appears as radio-opaque line. Now, in some cases, you can also appreciate inferior nasal conge. So, when you have studied the lateral wall, anatomy of the lateral wall of nose, you might be studied about the conche on the lateral wall of nose. So, we have the superior, middle, and the inferior conche. And the inferior conge sometimes might be visible as a radio-opaque shadow in the incisor radiographs inside the nasal fossa. Now coming to the soft tissue shadow of the nose. So the soft tissue shadow of the nose can be visible as a radio opacity, a diffuse radio opacity across the root of maxillary anterior teeth. This is mostly seen in projections of maxillary central and lateral incisors. So in some cases, you might be able to appreciate even the radiolucent nares. Now coming to the next one is the lateral fossa. Lateral fossa, you know, when you run your finger through your maxillary vestibule, you can find that there is a dip in the lateral incisor region. This is mainly because the thickness of the bone is less there. So when compared to the adjacent area, X-ray will easily pass through this area. So this will appear more radiolucent when compared to the adjacent area. So this is known as the lateral fossa, and it is otherwise known as incisive fossa or canine fossa. Then we have the inverted Y line of NS. This is mainly a structure which is formed because of the fusion of the anterior border of maxillary sinus with the border of the nasal cavity. So the floor of the nasal cavity and the anterior border of the maxillary sinus join together to form a inverted Y line shaped structure, which is known as the inverted Y line of NS, and this is mostly appreciated in maxillary canine radiographs. Now, this is another structure which you can appreciate in maxillary canine radiographs, that is the nasolacrimal canal. So, as the name implicates, it's the canal connecting the lacrimal gland and the nasal cavity. And that is why, because whenever you crying, you will get nasal leaking. So, the opening is found mainly at the lateral wall of the nasal cavity. So, when you take maxillary canine radiograph with steep angulation, you might be able to appreciate a round radiolucent structure just above the maxillary canine. So, and it is more visible in case of occlusal radiographs. Now, the next one is the nasolabial fold. So, whenever you smile, you can see that there is one fold which is formed just on side of your nose. That is the nasolabial fold. And behind the nasolabial fold, we have the thicker chin. So, the thicker chin will appear more radio opaque on the radiograph, which creates a sharp demarcation at the line. So, this is appreciated most commonly in the maxillary premolar radiographs. Now coming to the maxillary sinus is most commonly appreciated in premolar and molar radiographs of maxilla. It can be seen as a radiolucent cavity which is having scalloped borders, and there are some radiographs where you can even find radio opaque bands within this sinus. This is known as the septa of maxillary sinus, and in some cases you can also appreciate radiolucent lines within this sinus, which is known as the nutrient canals. Now coming to the next one, we have the zygoma and the zygomatic process of maxilla. So zygoma, it is the malar bone or the cheekbone, and zygomatic process of maxilla is the area where the zygoma get attached to the maxilla. So the zygoma is appreciated as a radio opaque shadow over the maxillary molar region, and the zygomatic process of maxilla can be appreciated as a J-shaped or U-shaped radio opacity superior to the maxillary molar region. Now coming to the maxillary tuberosity, it is the most bulge which is seen distal to the maxillary third molar region, and it appears as a radio opaque bulge just behind the maxillary third molar region. And this area we can also appreciate another one structure which is known as the pterygoid plate. And pterygoid plate is mostly seen as a diffuse radio opaque shadow. And how you differentiate it from the other structure is that there will be no trabeculations here. The other structure seen in this area is the Hamler process, which can be appreciated as a hook-like projection posterior to the maxillary tuberosity area. Now coming to the coronal process of mandible. Now coronal process is that part of the mandible which is visible in maxillary radiograph. That is why it is being discussed here. It can be seen as triangular radio opacity when you take radiographs of maxillary molar region. So just inferior to the maxillary tuberosity region. Now coming to the anatomical landmarks in mandible. So mandible is the largest and the strongest bone of the face, and it have three parts, mainly the ramus, body, and the alveolar process. So the first anatomical landmark discussed in mandible is the genial tubercle. Genial tubercle is the bony projections which is mainly seen in the internal aspect of the anterior mandible. So these are the projections which give attachment to the genioglossus muscle and the geniohyoid muscle. So when you take a radiograph, you can appreciate it as a ring-shaped radio opacity below the apex of the mandibular incisor. Now inside this ring-shaped radio opacity, you can appreciate there is a radiolucent dot, which is the lingual foramen. So lingual foramen is the area where the incisive nerves and vessels comes out. Then we have the nutrient canals. Nutrient canals can be appreciated as vertical radiolucent line extending from the apex of the root downwards, which carries the blood vessels and nerves towards the root. Then we have Mendel ridge. Mendel ridge can be appreciated as an inverted V-shaped radiopacity extending from the premolar region to the incisor region in the mandibular anterior radiographs. Sometimes we can also appreciate it superimposing onto the root of mandibular anterior teeth. Now we have the Mendel fossa in the same region. It appears as this is mainly because there is a dip just above our chin. So here the same thing that we have less thicker bone there. So the X-ray will easily pass through it, giving a radiolucent shadow when compared to the other area. So it is seen as a diffuse radiolucency in between the root of mandibular anterior teeth. Then the symphysis is the area where the mandible, two halves of the mandible fuses together. So the mandible develops in two halves and it fuses together in the symphysis at the midline. So this can be appreciated in younger kids, but not as the age advances, this symphysis get fused. So we will not be able to appreciate this much in older individuals. Now the Mendel foramen is the opening of the mandibular canal. It is seen on the external aspect of the mandible and this can be seen below the apex of the mandibular premolar region. So it can be either noticed below anywhere between the first premolar and the first molar. So when sometimes it can be superimposed just below the periapical region of a carious teeth. So there we can have a misdiagnosis whether it is a Mendel foramen or if it is a periapical pathology. Now we have the external oblique ridge. External oblique ridge, it is a continuation of the ascending ramus of mandible up to the distal aspect of the third molar region. And it is seen as a thick radio-opaque band extending downwards and forwards from the anterior border of ramus towards the distal aspect of the mandibular third molar region. Similar to this, we have an internal oblique ridge also, which is seen on the internal aspect of the mandible. So whenever you take a radiograph and you are seeing two radio-opaque band in this region, then you should identify that the superior ridge will be the external oblique ridge and the inferior one will be the internal oblique ridge. Now, this internal oblique ridge is found to be continuous with the mylohyoid ridge. Mylohyoid ridge is where the mylohyoid muscle gets attached. So, mylohyoid ridge will be seen as a continuation of the internal oblique ridge and it moves from the molar region towards the anterior aspect of the mandible. Then we have the mandibular canal. Mandibular canal is seen as a radiolucent band below the apex of the mandibular molar teeth and it is having a radio-opaque line on either side, which is the superior and the inferior border of the mandibular canal. And it is through this the mandibular nerves and vessels travel. It's opening from the mandibular foramen and it ends in the Mendel foramen. Then we have the submandibular fossa. So as the name implies, it is a fossa which lodges the submandibular gland. You know that the submandibular gland is being lodged in a depression in the lower, just above the lower border of mandible. So here we have a thinner bone and so that area will appear more radiolucent when compared to the adjacent area. Now lastly, we have the inferior border of mandible. So inferior border of mandible is made up of thick cortical bone. So it appears as a thick radio-opaque band of bone. So with this, the anatomical landmarks is over. So now we'll move on to the questions that have been frequently asked from this topic. Mainly in Pondicherry University, there are questions like enumerate the normal radiolucent and radiopaque landmarks of mandible with a neat diagram have been asked for 5 marks. Similarly, in case of maxilla have also been asked. So whenever the question is like enumerate the landmarks, you just have to list out the landmarks with a neat diagram. But when the question comes like enumerate and describe, then you have to name the anatomical landmark and also give a description with a neat diagram. The most important question that have been asked in Kuhas University is the diagnostic significance of lamina dura. So when a question like this come, you have to draw a neat diagram of the tooth and the supporting structures. You have to label the diagram and then you have to write about the lamina dura, how it is seen, what are the variations that can be seen in normal lamina dura, and what are the condition, pathological condition which can cause a different appearance of lamina dura. And also there are certain questions like enumerate the normal anatomical landmarks seen in the IUPA of maxillary central incisors region. So when such questions come, you have to be very specific about the landmarks which is seen particularly or specifically in the maxillary central incisor region. This is a question which has been come in Manipal University. Then we have another essay on anatomical landmarks seen on intraoral periapical radiographs. So here the entire topic have to be elaborated. Now there are also a few other questions where you can add this as a part of your answer. It is like when questions ask like differential diagnosis of periapical radiolucencies of jaw or multilocular radiolucencies of jaw or any periapical radiopacity of jaw. So if such questions come, how will you answer this? Mostly the answer will be like differential diagnosis is mostly classified like true periapical radiolucent lesion and false periapical radiolucent. So here you can see that the false periapical radiolucencies is containing mostly the anatomical landmarks. So what all anatomical landmarks that can mimic a periapical radiolucencies should be added here. And similarly for multilocular radiolucency, you can think of maxillary sinus, which is having a multilocular appearance. And for periapical radiolucency, radio-opacity, you can think of genial tubercles, genial tubercles, zygomatic process of maxilla. These all, when superimposed over the periapical region of teeth, it can mimic a periapical radio-opacity. So with that, I would like to conclude. Thank you for giving me a chance, and I thank ASMIC and ASMIC members and Assisia Dental College for giving me a thanks for being a resource person in this rapid review. Best wishes for your exam.
Thank you, Dr. Shaina. That was a very elaborate and crisp session. So any doubts, participants? It's an important topic. Ma'am has already discussed about the questions and everything. So I guess there are no questions in the chat box. Things are clear for the students. So on behalf of ASMIC and Assisia Dental College organizing team, I would like to thank Dr. Shaina for such a nice session, and I would like to present the certificate. Thank you, Dr. Shaina.
Also, I would like to thank Chitra ma'am for being my moderator.
Thank you, Shaina. So we come to the end of another session of rapid review, and tomorrow we will be seeing again. So we will wind up for today. Thank you, everyone. Thank you, all the participants, students, and faculties present here. Thank you to the resource persons as well. Good night.